Good evening, everybody. Welcome to Focus on Glaucoma. My name is Drew Keys, Program Manager for the Western Pacific region of the International Agency for the Prevention of Blindness. I'd like to begin by acknowledging the Bedigal people who are the traditional custodians of this land on which we meet tonight. I'd also like to pay my respects to the elders, both past and present, and extend that respect to the emerging leaders and other Aboriginal and Torres Strait Islanders who are present here today. I'd also like to welcome all of you who are joining us from places all around the globe. Each year, IAPB and Allergan join forces in early March during World Glaucoma Week. This year, we've had 22 incredible speakers focus on glaucoma from all around the world. On Monday, we heard about affordable and sustainable innovations across Southeast Asia. Tuesday was innovations for adapting the pandemic in Latin America. Yesterday, we heard about the change required to address racial inequality in the United States. And then last night, a new glaucoma toolkit was launched in Africa. But what we're most excited about is to cap off the week. We're here co-hosting with Vision 2020 Australia, and it's an event in person. How great is that? Welcome to the Roundhouse, everybody. Without further ado, I'd like to hand over to the IAPB Western Pacific Chair, Ms. Amanda Davis, for the official welcome.
Good evening, everybody. Welcome to this amazing event. We've got a very elite group here, and we're beaming out globally, so I'm very, very happy to have you all here. I too would like to acknowledge the Bedigal people, the traditional owners of the land, and I pay my respect to elders past, present and emerging, and any Aboriginal people that are present here or online. In 2019, the World Report on Vision was launched, the first ever WHO report on vision, and it reported conditions both treated and untreated. Of course, glaucoma came out as one of the leading causes of blindness. The World Report on Vision also set out an integrated people-centred eye care approach, a critical piece that means that we can integrate primary eye health into healthcare. What it also did was point out to us the importance of looking at the continuum of care, looking at promotive, preventative, treatment and rehabilitation. And this is critical as we know that most people living with glaucoma are not diagnosed and are not being treated. The increase of the ageing population, and particularly in this region, so too are eye diseases relating to age, which includes, of course, glaucoma. Now, this has been quantified in its significant impact on health, productivity, quality of life, and of course, OH&S. And recently in the Lancet Commission that was launched on global eye health, we saw that that was conclusive that vision loss and eye disease were associated with poor quality of life outcomes. In low and middle income countries, the impact is even further compounded. We know that there's a lack of services and equipment. There's a shortage of eye care personnel to be able to address these problems. And there's limited health literacy, and we need to increase that health literacy related to glaucoma. IPB, or the International Agency for the Prevention of Blindness, is a member-based organisation. It's made up with broad skills. We have clinicians, we have NGOs, we have Optometry Association, we have the Ophthalmology Association, and we are represented here very well across the breadth of those skills. And the IPB is focused on bringing much needed and sustained change in the world. One of these ways is to connect and learn, and hence why we have this esteemed panel with us to learn from tonight. I'd like to welcome our guests here in Sydney, our elite group here in Sydney, and of course our special guests online from wherever you're watching. We have some incredibly knowledgeable and talented panelists here tonight that you'll be hearing from. We welcome you and we thank you so much for your generous time in sharing your learnings with us. I'd like to thank our co-hosts, Vision 2020, and welcome them as well. And finally, I'd like to acknowledge and thank the sponsor for this event, Allergan. We truly appreciate your generosity to enable us to have these sorts of events. So thank you very much. Welcome, hope you enjoy the evening. And I'd now like to throw to a video welcome from His Excellency the Governor-General, Mr. David Hurley. Thank you.
Hello everyone. Can I begin by acknowledging the traditional owners of the land and pay my respects to their elders past and present. As patron of Glaucoma Australia, I'm delighted to provide this welcome message for Focus on Glaucoma, a virtual event to mark World Glaucoma Week. The Focus on Glaucoma initiative was first launched in 2019 to help shine a light on the fourth leading cause of blindness, glaucoma. In World Glaucoma Week, the International Agency for the Prevention of Blindness and Vision 2020 Australia have joined forces to deliver an event that focuses on both glaucoma and the important work being done to improve its detection, treatment and prevention. In Australia, we are privileged to have some world-leading researchers in glaucoma. This event will provide an opportunity to showcase some of their work. The perspectives of people affected by glaucoma are also important. I congratulate Glaucoma Australia for its advocacy of people with glaucoma and their families and for contributing to today's event. Glaucoma is one of the leading causes of irreversible blindness in the world. By working together and combining our knowledge and expertise, we inch closer to reducing this trend. I wish all participants at Focus on Glaucoma a productive and rewarding event.
To introduce our panellists, I would like to introduce the panel moderator, who has more than 20 years' experience working in our sector as a clinician, an educator, and an implementer of strategic design. Please put your hands together for the IAPB Head of Knowledge, Ms. Jude Stern.
Thanks, Drew, and thanks, Amanda, for opening us our session today. It's such a pleasure to be here and to see faces in the audience that we can see your reactions to what we're saying. It's really wonderful, and it's wonderful to have everybody that is online as well. Welcome to Focus on Glaucoma, Q&A style. Tonight we're talking innovation. We're talking innovation in technology, innovation in systems, and all things glaucoma. Will we be able to stop or prevent glaucoma in the future? Will we be able to reverse blindness one day? Can we get more people to seek services? Can technology or systems increase access to care? What is needed to put people at the centre of glaucoma care? There are so many questions, and we have just the right people here tonight with me to answer these questions. So I'd like to welcome them. Joining me tonight, we have on the end screen down there, beamed in from Melbourne, Professor Keith Martin, a pioneer of new treatments of eye disease using stem cells and gene therapy, and he's the Managing Director of the Centre for Eye Research Australia and Head of Ophthalmology at the University of Melbourne. Oh, I think you guys sat in the line that I have. Next we have Professor Lisa Key, a leading global researcher who's focused on policy-relevant research. And Lisa is the head of the School of Optometry here at UNSW and the Honorary Professorial Fellow at the George Institute for Global Health. We have Associate Professor Mitchell Lawler, who's been driving improvements in patient outcomes in glaucoma. He's a glaucoma specialist at the Sydney Eye Hospital and the University of Sydney, and has long-standing commitments working across Asia Pacific. And our fourth member of the panel is Annie Gibbons, a powerful force in the war against blinding impact of glaucoma and fighting preventable glaucoma blindness. Annie is the CEO of Glaucoma Australia. Would you all please make them feel welcome? And being Q&A style, the audience gets to ask the questions tonight. And so we have our first question coming in from Eric Pappas. If you could just come down to the microphone to ask your question. great question to start off with. I'd like to throw to Keith in Melbourne to answer that question.
So I couldn't hear the question, so if you'd like to repeat it for me, I can hear you very clearly, but I can't hear the questions from the hall.
Yeah, maybe try a different microphone. Yeah, so it's about, the future, really. So we're talking innovation tonight, and I'm just wondering what the future looks like maybe in 10 years' time, what glaucoma treatment may look like in 10 years' time, and what the outcomes of that treatment might actually be. And also, of those things that we can look forward to, what kind of things are already happening as we're aware of right now? Did you get that?
Yeah, well, that's a great...
Good.
Great question, and I'm sorry I'm not there with you in person. I think we're nearly there in terms of being able to travel freely again, which is great, and hopefully the next time it'll be a lot easier. But no, great question, and I spent a lot of my time sort of thinking about how glaucoma is going to look a few years down the line. And I think this is a really exciting time for glaucoma because there's a lot of innovation going on in the field, and that spans across diagnosis as well as treatment of glaucoma and for treatment in the medical, surgical, and laser fields. So I think how things are going to change. I mean, 10 years is quite a reasonable period of time, and I think a number of things. If we start with diagnosis, I think diagnosis will become more automated, and I think we'll receive more decision support from artificial intelligence algorithms to help us diagnose glaucoma. I think we'll be better at sort of structure and function correlation, in other words, putting together information about how the eye functions with how the imaging devices capture it. I hope we will be getting away from as much dependence on visual fields. We all hate doing visual fields, and I think there's been real progress in terms of learning what are effective predictors of visual field change, and I hope that will continue to the extent that we won't need to do visual fields to the same extent as now. I also think we'll be using more intraocular pressure sensors, and I think they will be incorporated into intraocular lenses that we put into patients with glaucoma. I think it'll be possible to include intraocular pressure sensors in glaucoma drainage devices, and I think that's going to provide us in the early years with a whole lot of information we don't know what to do with. We don't know how useful that information will be, but I think that will be technologically possible. And I think in terms of diagnosis, we will also be using genetic risk profiles to influence our treatment decisions. So I think within 10 years, very many of us will have access to information about our own genomes. It's already cost less than $100 to do this now, and there's very strong work going on in Australia looking at the creation of genetic risk profiles for prediction of who's most likely to develop severe glaucoma, because that's who we want to be targeting our treatments to. In terms of treatments, I think I work in the field of trying to develop treatments that protect over and above the effect of lowering pressure in the eye, and that is both looking at therapies that we can all potentially take that could benefit glaucoma, and we're very interested in the vitamin B3 in that regard, and we're about to start a big international trial in that regard. But also treatments which, when glaucoma is very severe, can potentially restore vision. And again, we're working on gene therapies, and I would expect that within that time period we will have started and hopefully finished some trials using gene therapy for glaucoma to protect the optic nerve and ideally to restore some function that's been lost. And then we're working towards regenerating the optic nerve as well. So certainly in animal models already we can effectively regenerate the optic nerve, and I think it's possible within 10 years that we'll be starting to do that sort of work in humans. And so there are many other things, and I'm sure other panelists will be able to cover some of the surgical advances, or we can come back to those later on. But I'll pass the baton on to the other panelists now.
Thanks, Keith. That was great and so comprehensive, and so many exciting different areas of innovation. I mean, the things you were saying at the end there, restoring vision and regenerating the optic nerve, feels like there's a lot of potential to obviously with glaucoma, but other eye diseases as well. I want to throw it open to the panel now if they'd like to add any comments to that question, Mitchell.
Yeah, so Keith's given a really lovely summary of all the different areas where technology is playing a role. I'll maybe pick out one area which is looking at surgical treatments, and that's an area where it's quite interesting. There's a really diverse audience here, and I think we have to keep in mind that some of the comments really depend on the jurisdiction in which people are working. So here in a high resource environment where we work, we tend to look at medical therapy, then laser therapy, and then moving to surgery. In other low resource settings for logistical reasons, sometimes that's reversed. But certainly here in this area where I work, we start with medical therapy and then we move to surgical therapy, but there's a bit of a gap in between those two, that there's a fairly large safety risk in moving from medical therapy to surgical therapy. So an area over the last 10 years which has really flourished in glaucoma treatment is looking at different surgical techniques, and often particularly devices that help to bridge that gap between the two. And so some of the work that we've been doing is looking at those new devices and trying to understand where they may fit into the treatment paradigm. And because often things that are new are thought of being great, but we know that that's not always the case, and these things have to be tested, they have to be checked. We have to look for efficacy, we have to look for safety, and then also look at cost effectiveness. But this is an area where we can probably chat a little bit later about that, but looking at, there's a lovely plethora of options that are coming surgically, which I think will have immediate benefits for many patients in the short term.
Lisa, Annie, anything you want to add?
Sure. I think, there's such exciting options, and I think that as these become available, we'll want to be really looking at the equity and access and making sure we reach the right people at the right time. And, fortunately, like you said, we work in a high resource setting. We've got the capability to do this really well. And I also wanted to highlight that some of the initiatives are right from the diagnostic point and picking up people at risk, right through to fantastic innovations in treatment. So I certainly think it's really exciting times, and keeping the patient at the centre and making sure we get the right people through the right place will be absolutely to realising the benefits.
I think the two key words that I hear from people with glaucoma is that they're wanting to be hopeful that research is happening day in, day out to improve the lives of hopefully themselves, but definitely generations after them. So it is really exciting, and it's an exciting time in glaucoma that there is so much research, significant research happening, particularly in the area of optic nerve regeneration and certainly the genetic testing. I think it will just change what we're doing. We already have benefited greatly from, the target research that's told us that, direct relatives are 10 times more likely to get glaucoma, but to be able to then get those relatives to actually be able to just get genetic tested, there's so many aspects that are exciting from a patient perspective that reduce their anxiety, that can make them more proactive in their health care. And then besides hope, they're wanting to be confident. They're wanting to be confident in their eye health, right? And so being confident means that they're very sure of the treatment, all the options available to them, and that they can take them in a very convenient, timely way. We've definitely equity and access issues considered.
Wow, we've covered a really good range of innovations from, the dream pipeline ones to ones that are happening now, and certainly the ones you're talking about where we're just putting the patient at the centre. I'm going to go to our second question, which actually comes in from our live feed, I hope, from South Korea. We have Dr. Sang-chul Yoon, who is going to ask a question now.
Hi, I'm Professor Sang-chul Yoon at Yonsei University, South Korea. Aging population is placing burden on health system in Korea and many countries. What innovations and new approaches has been tested in Australia to reduce the burden and increase access to service for glaucoma?
It's a great question, and I'm just, the audio is just a little bit soft, so I'm just going to repeat the last part. What innovations or new approaches have been tested here in Australia to reduce the burden and increase access to services for glaucoma? Lisa, did you want to start with this one?
Sure, I'd love to answer that question. Thank you for that. It's a really important question, and there's quite a few initiatives around Australia which have tried to tackle access problems for getting, like I said earlier, the right treatment at the right time to the right people. I've been involved in one such model, and I want to recognise that other countries, particularly places like the UK and parts of Europe, have really embraced these models for some time. But in Australia, we've really had pilot models and different innovations out of different hospitals, really locally based. But I've been involved with the CIC model, which was a model in Australia where we tried to set up community-based optometry-led clinics that were integrated with the tertiary ophthalmology clinic at Westmead Hospital. So the idea was to triage the low-risk referrals so that they were go through a standard protocol. It's still linked with the hospital and has some checks with an ophthalmologist with a stored information that was then reviewed in batches. So it's a model that's been in place in other settings, but it was new for this district in Australia. And we were fortunate that we could evaluate the model. We recognised that hopefully this is going to be efficient. We're going to get people through the system more quickly, and we could get the waiting times down from somewhere in the ballpark of 400 days right down to just a few months waiting time. 86 days was our median. But importantly, when you go to these team-based care where you're utilising other practitioners, such as optometrists in this case, but nurses, orthoptists, other professionals, you can deliver care that's more lower cost. And we found that the cost of this care through this model was 22% lower for the health system. So it's a good thing for the health system to invest in. And I guess, part of the question was about scalability. So if this is such a good idea, why aren't we doing it everywhere? But it's a change, and it's a reshuffling, and it's a delegation of duties to other practitioners. So it does require a bit of effort to make the change. I mean, this model, Associate Professor Andrew White was the clinical champion, and we know from talking to people in other settings that a clinical champion's absolutely critical. Someone's got to want to make this happen. And really, we've also got to highlight the failings in our systems. And even though we've got a very wealthy country with a fantastic health system, we can really fail a bit on chronic conditions like glaucoma, where people aren't getting through very quickly and there can be access blocks. So if we recognise that as a safety risk and really recognise that we have to do something, then we can get these innovative models in and get them to be sustainable. So there's a lot that we can do more with just the treatments that we have now. So with good medical management, good surgical management, getting to the right people, we can really make a difference, I think. So it's been exciting, and hopefully it's a model of care that more and more services will take on similar models.
Thanks for sharing that model with us, Lisa. I'll open up to the other panellists. Annie, you look like you have something to say.
Yes, from the patient perspective, we have, great concern about those disadvantaged, the aged, the people in rural and remote areas, those of culturally and linguistically diverse backgrounds, those with disabilities, to be able to access care. And so, as well as that, we're aware as a patient organisation that the more empowered the patient is, the more adherent they are, the more understanding they are of their whole treatment. And so in 2018, Glaucoma Australia designed a referral response pathway, which basically means that everybody who gets referred to us, whether it's themselves or any eye health professional, they join a patient support journey. And that's allowed us to give them a 4-stage journey, whether they're a suspect, just diagnosed in that first 6 months or 12 months ongoing, and we give them tailored support. And while we aren't able to give them clinical examinations, we are able to take a lot of that time with the patient that hopefully will be saving the time at the clinicians. We're able to have orthoptist educators answering all their questions. This information is also supported online. Our website has just got all of the best information available to our patients, which is really helpful for those who can't access it other ways. And it's also scalable because we've been able to implement an electronic communication pathway that helps patients at all stages of their journey. And hopefully it'd be able to be implemented across the world and shared as a platform. So it's been really exciting in that way, and we've definitely noticed that the adherence rates of patients has been improving, and we're now getting data to support that from the support that they get.
So glad you highlighted a innovation, like just using a communication system and support system that, is technology that is already existing, but using it for a purpose to meet patients' needs.
Yes. It is very exciting because, we only need to look at, 4 or 5 years ago and everything was paper-based or just a telephone. And now these models that we've designed, not only the patient can look at the website, they can get text messages, they can get electronic communications to their email, they can get automated communications based on the questions that they ask. They could go to a web chat and ask a question direct with an educator. So it is actually very exciting to be implementing these innovative pathway opportunities for our patients, and it's definitely making it more equitable for those who aren't in the metropolitan areas.
And I'll just quickly throw this question to Keith or Mitchell.
Yeah, I think great points from Lisa and Annie. And one point I would make is that I absolutely agree that technology is key to making these schemes work well. I think we have to make best use of community optometry, and we don't always have to reinvent the wheel. I mean, there are plenty of good models out there, and Lisa highlighted Andrew White's work, and Andrew we had in Cambridge in the UK a community scheme running for many years, and Andrew was my fellow there, and we tasked him with running this thing for a year while he was there, and hopefully he's taken some of that back and has actually improved it, and that's as should be. I think these are dynamic, programs, and we can all learn from each other and make them better and take what works from other places, and I think that's a healthy thing to do. And technology is key to making these work. Again, it's so much easier when these systems are electronic and you've got good communication and good information flow between optometry and ophthalmology. And the other point I make is that COVID has been an opportunity here. I think we're all now looking for new ways of working that avoid having people in crowded hospital outpatient departments moving into the future. And so we're developing ways of better community care, better home monitoring. All of these things I hope will be accelerated by our response to what's been a fairly miserable year from the COVID point of view.
Yeah, I mean, I echo your comments about the global exchange, and I think it's great to be here with IAPB and talking with people from South Korea and sharing our experiences in Australia. And sometimes when I've spoke to people from other settings, they can implement these things very quickly. We're quite bureaucratic here. Getting a change in a big hospital is really hard. And there's a lot of logistics, there's the privacy of information transfer that has to be tackled, and that's why it literally takes years sometimes to get these things up and running. And there's a big team that worked in this, getting these models of care, but they really can make a very big difference, I think.
Yeah, and as you said, Lisa, this is exactly why we're doing forums like tonight, is to be able to exchange those ideas across the globe. And speaking of which, we have another speaker coming in from Malaysia. We have Mr. Pak Seung Woon, who is the immediate past president of the Malaysian Optometrists Association. So hopefully he'll just come up on the big screen.
Good evening and congratulations on this IAPB Focus on Glaucoma 2021 event. My name is Woon and I am an optometrist from Malaysia, and I have my own private practice of optometry. First of all, I'd like to thank IAPB very much for all the good work that you have done in the past as well as you are currently doing. I have two questions to the panel. First, what is the most resource-effective way for us to deploy as a nation to combat blindness by glaucoma? Would artificial intelligence or teleglaucoma, or even opening up to more healthcare professionals to widen this net so that we can achieve this objective? The second question would be, in the Lancet launch this week, there are studies around how to improve the quality outcomes in delivering cataract services. And quality is one of the indicators being suggested to monitor World Health Assembly resolution progress. So with this in mind, can I ask the panel, what is being done to improve the quality of glaucoma treatment outcome? With these two questions, thank you very much.
Thank you, Woon. And we're going to take the second question first, hopefully not confuse anyone. Mitchell?
Like the two great questions, huge questions, which we could discuss at length. So taking the second question first. Look, it's very interesting. I think we can learn a lot. The world in general. We've done quite well in terms of getting through or reducing the burden of blindness from cataract, but I think there's a few things that we've learnt from that. One of it is that there's sometimes been quite a strong focus on numbers of cases done rather than quality. These are very general comments that I'm making here, but and I think that there is a bit of a problem if you don't focus on quality, that you can take somebody who's got reversible blindness due to cataract, and then if you do a bad cataract operation, you give them irreversible blindness due to uncorrected refractive error where they can't access spectacles, for example. And so I think there really, and this is certainly the way things are going, is very much trying to focus much more on quality. And I think as glaucoma sort of moves up the chain to a disease where we start to look into it further, that's something that we can certainly learn from. We've done a little bit of work in this space looking at, we convened a group across Australia and New Zealand who defined a minimum set of clinical indicators to track a patient's journey with glaucoma. So what are the minimum few things that we can identify to understand a bit about that pathway? And that obviously includes clinical indicators, but it also includes patient-reported outcome measures, which is clearly very important in the space. And this is a registry that we now have running that tracks patient outcomes over time, and that can be used to look at medical therapy. Particularly we're looking at laser and surgical therapy initially, but I think using things such as registries are a really good way of looking at quality over time. Individual clinicians can use the registry to see how well am I performing, and they can also see benchmarks from across the entire registry. So I, as a surgeon, can see how is everybody in Australia and New Zealand performing doing this procedure, and if I'm not up to scratch, I can see that in very nice graphical terms, and then I can remediate to try and improve where I'm not doing well. And so I think again, there's a bit of a theme here coming through, using technology and using that to aggregate data, because we have so much data now that a lot of the focus is on how do we not only capture the data, but how do we analyse it, and then more importantly, present it back to clinicians who can then use that to improve their practice. And so a lot of that's what we do. I'll leave the first part of the question if you like to, that's another kind of...
We'll put the first part of the question into the Q&A, the Q&A after the Q&A. Keith, did you want to have any comments on the quality outcomes?
Yeah, and I think it's a really important question in glaucoma because I think one of the big questions in glaucoma, how do we know we're doing any good? You know, it's pretty easy after a cataract operation to know that you know, and as Mitchell said, we should be measuring the quality of the outcome, not just the numbers, but it's something that we should also apply to glaucoma. And you know, what is the evidence out there that actually glaucoma treatment makes a difference to patients? And this factored into the original discussions around Vision 2020 right back, because you know it was more difficult with glaucoma to determine whether the effectiveness of the treatments that we have. We do have better evidence since, and when you look at big series coming out of places like Mayo Clinic, there's been a reduction in the rates of blindness between 1970 and 1980, and then 1980 to 2000. So the rate of blindness in at least one eye halved during that time, which is sort of a suggestion that we are doing something right. So the rate of blindness in one eye fell from about 26% to about 13% over that time in that population. But I would challenge those of us that manage glaucoma, do we actually know what the rate of progression is in our own clinics? Do we know how many of our patients are actually getting worse? Do we know how that compares to other populations around? Are we doing a good job? We may think we are. We may think our operations and our surgery look great and our treatment protocols are great, but how are we auditing what we do? How are we benchmarking what we do? And I think there's room for improvement there, and I think registries are a great way to go in that regard. And Mitch has been involved in this work as well, at looking at what the outcomes of some of these new surgical procedures are. We should be self-critical and constantly evaluating the success of what we do. And again, we've done this in various hospital settings. You know, for the community glaucoma scheme, we're just about to publish a paper looking at the rates of progression in our community optometry schemes in the UK compared to hospital care, and demonstrating lower rates of progression, as you would hope, in the community compared to the higher risk patients in the population. But at least that gives us some sort of idea of what the starting point is, so that we can measure whether any things that we do in the future actually are making a difference to the outcomes for patients.
Yeah, actually, I just wanted to pick up a little bit about quality of care, because we some of the research we did, and I'm sure that Annie's got some really great perspectives on what patients believe quality of care is. But I was quite staggered by the results when we spoke to a series of patients with glaucoma who are getting ophthalmological care, and we said, what is quality care? And it was so hard to have this conversation. It didn't roll off the top of their tongues like we're saying here. Like, you know, Mitchell and Keith can very well articulate what good care is, less progression, all of your clinical endpoints. But what patients say is they really care about who they see. Is it the same person? Is it a person who'll speak to them, you know, familiarly and allow them to ask questions? So that was really grounding for me. And we also found that patients have a lot of trust in their doctors, which is great. It's obviously well-founded, and but they really care about the interaction, and I think that's really important to keep in front of mind as well.
So I think when we were talking about that a couple of weeks ago, it's really stuck with me as well, you know, across everything, you know, the patients wanting the consistency of the doctor, the time to talk, you know, linking in with what Annie's initiatives have been. I think this leads quite well into our last question for the formal part from Davina Brain. I'll give you this microphone.
Thanks. Thank you, everyone. And this has been touched on to an extent already, but the World Health Organization calls for a people-centred approach in health services. But frequently it seems that, particularly in eye care, the discussions are more about the systems and the processes. And I was wondering, rather than the patient, and I was wondering if you think that that is a problem in glaucoma care, and if so, how do you think we can ensure that the design of advocacy campaigns and patient services actually have the patient front and centre?
Thank you. I think, Annie, that has your name all over it.
I think there's a lot of evidence that shows that health systems which are oriented around people and their relatives and their communities are definitely more effective. They cost less money. They result in better health literacy and engagement. And that's what we want, right? That's what we want for our patients. That's what our patients tell us that they want. They want to have a role in acquiring the information that they need to feel confident in their eye health care. They don't want to be a passive recipient in that care. And not that we're saying that they do get to control what's happening. Of course, we fully support the healthcare model, but we do need to constantly be asking our patients, well, what do you need? What do you need at this time? And how do you need it? You know, and that's been a big part of our referral pathway, that we've dropped it into different stages and sections, that people were getting overwhelmed if they get too much information at a certain time. We might be able to say, let's hold off on that and let's hear what you really need at this time. So it's how we communicate, it's the language we use, it's the asking the patient all the time, what do you need at this time and how can we deliver it? And that's why we deliver through different mechanisms now. You know, that we can have the best designed care and technology, treatments, but it doesn't work if the patient doesn't believe in it. It doesn't work if the patient doesn't say, you know, this is going to be helpful for me. And this is why our adherence rates are so bad. You know, how can you have glaucoma drop adherence rates at 36 to 50% by the time they've only had glaucoma for 12 months? This is just appalling, and a lot of the reason is because the patient doesn't understand the need for that medication. And there's a whole lot of complex factors in that. It can be cost, it can be distance, it could be the priority, it could be the value. It might be that they didn't understand why they needed that medication. They might not have understood that they could go on a change treatment if it didn't agree with them. There's so many complex factors. So I suppose for a person-centred healthcare model, it's about making sure that we do understand what that person needs, taking time out to get out of our medical model and see it from the consumer perspective, and always be asking, what do you need at this time, and work around that.
Thank you. I invite it to the panel for other comments.
Sure. I mean, I could build on that a little bit more. I think the important thing to note with a disease like glaucoma, that it is a chronic condition. So people don't just need to access care on a single occasion and get a single treatment. They need to be monitored. They need to be coming back. So they need to be continually accessing care. We did a piece of research talking to using a quantitative method with about 100 patients who were accessing care for glaucoma. And what we were able to do is quantify the different factors that determine whether or not they'll seek care at a particular service. And it's actually, you know, the thing that comes to mind is out-of-pocket costs. That's obviously a major determinant. And people with limited resources are often seeking care in what we would call public clinics, so there's no out-of-pocket costs. But we know that there's more to it than just cost. How long do they have to wait to get their care when they're in that clinic? And that was a determining factor. So once they arrive, are they going to be there waiting an hour to see someone, or are they going to be there for the whole day just waiting in queue? The other factors that were really important, and it speaks to what I said earlier, that they like to see the same clinician. They want a senior clinician as well. So those things were part of the equation. But just like whenever we make any decision about the things we do, whether it's purchasing a watch or you know, it's a multifactorial decision. So we look at lots of different factors, and that information should be used to design patient-centred care. So there's simple innovations that could be considered that aren't particularly costly. You know, would it be too hard to be able to tell people exactly how long they're going to wait? If it's an older person with particular concerns about when morning tea is going to be, you know, they need to know. So that they can plan their day, their carers who might have to take them to their visits. So speaking with people and getting these you know, quantitative methods have been really informative, and they do actually trade on these different things, whether it's waiting time or what they have to spend just to get the particular things that they value in a service. So really informative.
Yeah, look, I could probably just throw in maybe a clinical vignette just to personalise it. I think that the point of even just asking patients questions, and sometimes that can happen in a public clinic, you know, which I do very busy public clinics where they're very time pressured, but just taking the time to actually ask patients, do you have any questions? It's really simple, and it's very interesting the response you get, because that's actually just a routine part of closing out a consultation for me, is to ask that. And it surprises me sometimes that I'll see a patient who has very early glaucoma, and I've taken pains to sort of say, look, it looks great, the chance of visual morbidity in your lifetime is very low, but then do you have any questions? And the first question is, am I going to go blind with this? And so that just gives an opportunity that, because again, I tend to be talking, even though you try to make it non-technical language, patients just don't always absorb things because there's so much information going on, there's so much anxiety about the diagnosis, there's a range of things. And so at least you mentioned the chronic nature of the condition. And so I think part of this is an iterative process. Find out what's the salient issue here, and then at ongoing visits try to understand it, obviously using patient support organisations to facilitate that is part of it. But I think as clinicians we can always do better to try and make sure we position the patient as the most important person in that consultation.
Keith, did you want to add anything?
Yeah, just a sort of slightly cautionary note around, because it's hugely important to involve patients in the care and the rest of it. But Pradeep Romulo in the US has done some very interesting work looking at patient satisfaction with their glaucoma care and how their glaucoma progresses. And one of the problems with glaucoma being a chronic asymptomatic disease is that patients who are told that everything's fine, even if it's not, tend to be happier than those that are told they've got a problem and are put on appropriate management, because the quality of life gets affected by the treatment, and they worry more, but they're actually saving their sight in the long term by doing that. And so it's a balance, I think, in glaucoma between, you know, what the patient enjoys as part of the consultation process and what is high quality care. And that's an education piece. That's about talking to the patients and explaining to them, you know, what's going on. But it's an interesting disconnect that has been picked up in a number of studies.
Something that obviously has a lot more to be explored in the future. I'd like to throw the floor open to anyone here in Sydney that wants to ask a question. Is the mic there working? Or I can give you my mic. Does anyone want to come up and ask a question? Eric?
Sorry, this is the Eric Pappas show, I'm sorry. But I'm interested in what's happening with normal tension glaucoma. So when you've got good control of the intraocular pressure, but you've still got progressing field loss, what can really be done about that right now?
Maybe I'll go first and then Keith can probably chip in after that. The first thing to say is that we know that normal tension glaucoma, it is somewhat an arbitrary cutoff where we choose a couple of numbers, and if you happen to fall in those range before you start a treatment, you get that label. So there's some debate as to whether this is actually a separate condition or whether it's just a continuum of disease. And either way, we also know that if you reduce the intraocular pressure in somebody who has normal tension glaucoma, it reduces progression. So when caring for patients in this situation, the first thing we have to do is follow the principle of get the pressure down and make sure adherence is good, because that's another reason why we see this is not the case, why we do see progression. And then often we move to surgery a bit sooner than we would otherwise, as some of the trials have shown, because you can't reach a target pressure effectively. Is pressure the whole story? No. Is it the only thing we have at the moment? Yes. And so I think probably that sort of aggressive management, obviously depending on the clinical situation of an individual patient, is where we are now. And I think that probably segues to a lot of Keith's work, which is really exciting in this space as to what the next chapter of that might be.
Keith, did you want to add?
Yeah, and there's been a debate in the field for a long time now about whether normal tension glaucoma is a distinct condition, and you get quite polarized views on both sides of the argument. Some people saying, well, it's a completely distinct condition. Some people saying it's just purely a continuum. And I think the answer is probably a bit of both. There's some glaucoma is very much dependent on the pressure, and high pressures can injure nerves that have a normal amount of resilience. But I think there are a subgroup of glaucoma where the problem is the vulnerability of the nerve, and the nerve is more vulnerable to damage than in other people with glaucoma. And we haven't really got to the bottom of that mystery about why that occurs. We suspect some of them have problems with the blood supply to the optic nerve. We know some of them have mitochondrial problems because we've found the genes, but it's only a minority. And I think this is another area where understanding the genetic profile of patients will, in the future, help us target more appropriate treatments. And this is starting to happen. This is the whole realm of personalized medicine, where you use what you know about a person's genome to help taper the right therapy. So maybe some of the therapies we already have are more appropriate for certain people with certain genetic profiles. And I think that's going to be a really exciting area to watch. And there's a whole movement going on now for big international studies to incorporate genomics into them, so that we can identify what modifiable risk factors influence the progress of our disease. So in the future, if you do your 23andMe equivalent cheek swab and you know what your genetic profile is, that may predict that you need to be on vitamin B3, or you need to be taking a particular class of medication because you have the receptors that are most likely to respond to that medication. That will help us, I think, in the future, but we're still a little bit in the dark. And as Mitchell says, the one thing we do know for sure is that reducing the pressure, even in normal tension glaucoma, reduces the risk of progression.
Great, thanks. We're going to take a question that's come in from online via Amanda. Yep.
Actually, it hasn't come in from online, it's mine. Drew's got that one. I just wanted to talk a little bit about health literacy and just being mindful that we've got a global audience here. And one of the things that came out in the Lancet Commission was that there's more people undiagnosed than there is diagnosed and in treatment on a global level. In terms of some of the learnings that we've had in Australia in health promotion and encouraging people to actually get their eyes checked, What are some of those lessons you think we could share sort of more globally with our audiences to think about, you know, what does that look like in terms of advocacy and working with their governments to implement sort of those sorts of campaigns?
Great question. Annie, yeah?
I suppose from Glaucoma Australia's perspective, we've got a multi-layered sort of awareness campaign model. So at the moment for Glaucoma Week, we have Treat Your Eyes campaign that's just trying to get an awareness culture of people over 50 go and get your eyes tested every 2 years. Now that's a long-term model, and it's not going to find a lot of glaucoma, but it is going to in the future over time. Our next model was that we've been very strong on the Family Link campaign, and we've got a new one coming out called It Begins With You. So definitely, if you can target people who are 10 times the risk, we'd rather in Australia go to instead of going to 2.3% of that population, we go to 23. And so that has been very successful for us. We've gone from around 300 referrals a year to 300 a month just because we implemented a Family Link campaign. So that's very exciting that we're using that research to now target people. And another campaign we've used is called Don't Be Blindsided, which then goes and broadens it. It goes and says it's not just Family Link, obviously it's also ageing, African descent, Asian descent. So we're trying to use only a maximum of 4 primary risk factors. We've found that with our patients or our community, too much information it doesn't work. You know, if you have a list of, 6, 8 risk factors, that's not going to be helpful. So we're trying to get an eye health culture of get tested after 50, 40 if you've got a family history, and very much all of our main marketing is going to go to Family Link and try and find those undiagnosed through there, and that is working.
I think that's brilliant, Annie. That's exactly where you need to keep the messaging focused, and those are the ones that, it's age, it's family history, and it's that awareness, that how much greater your risk is if you have a family history, and keeping the messaging simple is just really, really important.
Yeah, I think all of those comments are really important in the Australian context. Just broadening it a little bit, I think, as with everything, the devil is in the detail, and it really depends on the context in which you're working and operating. So if you're sometimes in a very low resource environment where access to care is extremely limited, then there is a bit of a danger in terms of finding people who have very low risk of glaucoma and clogging up services. So I think you're obviously looking at it in a different part of it, because as glaucoma has come out of some of the discussion, there's not a test that just says yes or no for glaucoma. There's some people who definitely have glaucoma, there's some people who definitely do not have glaucoma, and there's this big group in the middle of glaucoma suspects, and how to handle them really underpins a lot of the health systems discussions that we've had here today, and also is really different depending on the underlying capabilities of the health system. So for example, in a very low resource setting, say in Southeast Asia where I've done some work, we would tend to more focus on opportunistic case detection, which is that if you're running a clinic and somebody comes in with a foreign body in their eye, look at their nerve and see if you see glaucoma there, and that's a really good way to pick it up. And check both eyes and do a proper full examination. So it's very much horses for courses and depends on the context.
Yeah, I think it's. I think that the messaging and the health promotion for detection is absolutely critical. But going to sort of the next stage, where do people have the health literacy to then get care? It's a complex system to navigate, and what we found is that people don't necessarily want a whole lot of information about the mechanisms of the condition. They choose to place trust in the people they believe know, which is the doctors and the optometrists and the people who are diagnosing their diseases and initiating treatment. So they're very trusting, which is great. But what we also want to say is that we need to empower patients a bit more, because what we found is when we said, so why are you getting treatment at this public hospital eye clinic? Why are you getting treatment in this practice? They said, I was told to go here. So we're not really enabling people, and I think we could do that more. And I think organisations like Glaucoma Australia can provide this broad advice there's different options. You can try these different things, because people could go down a pathway of a certain treatment that's got incredibly high out-of-pocket costs. They need to know that there's another option, and that sort of information's hard to find, because it's who's going to give that information if it's not an independent source like Glaucoma Australia or others. There are government websites, obviously, but I think getting people more involved in their decisions about their care is a really good point to pursue.
I think it's a really good point I'm going to wrap up here now because we're almost out of time, but at the other webinars we've had this week, the same issue has come up, and particularly in the Africa webinar, a specific toolkit for that environment has been developed to be able to enable the right kinds of communications and strategies and treatments that are relevant in those particular settings that it's designed for. On the US webinar, there was a lot of talk about that with African American patients who have a higher rate of glaucoma, and the messages are taken differently, or they're not as effective, and how do we actually cater for the populations we're trying to serve. So I think it's an area that's being grappled with worldwide, but it's great to see it being addressed, and hopefully there's a lot of cross-learning between all the different places where these studies are going on, and we can make the linkages to learn and grow quicker together and for our patients. So I'd like to thank you guys very, very much, and thank the audience as well for tonight. And I'm going to hand back to Drew.
Thank you, Jude, and please a big round of applause for our moderator and our terrific panel. This evening's event, and indeed focus on glaucoma all around the world, would not be possible without the generous support of Allergan. And so I'd like to invite to the podium Mr. Chris Stemple, who is the Vice President of Allergan Australia and New Zealand. Thank you very much, Chris.
Thank you, everyone, and thank you for that wonderful discussion. That was very educational. Over the past 70 years, Allergan, an AbbVie company, has enjoyed a proud history in discovering, developing, and delivering innovative medicines, including treatments for glaucoma. We are committed to advancing understanding and awareness of glaucoma and to providing solutions that help to preserve long-term vision. However, we know that glaucoma management goes beyond the treatment and requires a network of trusted partners. By working in continuous collaboration with eye care professionals and advocacy partners, such as the International Agency for the Prevention of Blindness and Glaucoma Australia, we can make a remarkable impact on the lives of people living with glaucoma and other preventable diseases. I'd again like to thank the panel for their great thoughts. I learned quite a lot. I saw two themes that I thought came out in particular. One was the use of new technology and how to apply it for blindness prevention. That ranged from new gene therapies that might protect the optical nerve through to text messaging and other ways to engage with patients and ensure that they felt empowered and supported in their care. In particular, we talk about particular interest for us is new surgical tools and techniques, and supporting clinical partners to understand how best to implement them into effective models of patient care. We also talked a lot about systemic change and the challenges and opportunities associated with systemic change, from new forms of multidisciplinary care and the bureaucracy that needs to be overcome in order to implement those, through to the evidence that exists in new forms of registries, and being very patient-oriented in our definitions of quality and how we think of care outcomes. So I'd like to thank the panel for their time, and I'm very pleased that we have the opportunity to support great discussions like this here and indeed all around the world. Thank you.
Hello everyone, my name's Judith Abbott and I'm the CEO of Vision 2020 Australia. So as the co-host of this evening's event, I have the pleasure of wrapping everything up and really saying thank you to a few people. I was reflecting on this evening and thinking about just how much things have changed since I saw my first patient with glaucoma a little while ago now. And really for me, the theme of tonight reflects something that Annie said early on, which I think it's about hope. You know, when we listened to Keith, we heard him talk about the remarkable innovations that are under development and what can be achieved and how that will change the lives of people around the world. We heard Lisa talk about some of the systems design changes and how we can all learn from each other and how different settings will really have a different approach to how they drive these improvements. Annie, as always, reminds us that if we learn from lived experience, if we place the experience of people in the centre of how we do this, if we have empathy and understanding, we can achieve not just a technical outcome, but a remarkable partnership between patients and the people involved in everything from research to care. And with Mitchell, his insights into quality assurance, I thought, and some of the challenges, with a little bit of kind of challenging from Keith there, really made us think about not just what we do, but how we understand and measure. So from the perspective of everybody here, I'd very much like to thank the panel who are all Vision 2020 Australia members and contribute to the work we do here in Australia, but also, as you can see, are making remarkable contributions to what we're all trying to achieve internationally. And I believe there are small gifts, and the lovely Drew is going to present them, but since we're tight on time, you can observe them being given presents, except for you, Keith. The rumour is you will get one in Melbourne. I will try to ensure that happens. So just one more time, thank you to the panel for their insights, their time and their wisdom. The second group of people I would like to thank are the people who make these things happen. So the supporters, not just of tonight, Allergan, but also the supporters of IAPB and Vision 2020 Australia, because they allow us to do things like this and everyone benefits. I would particularly like to recognise the IAPB team, and specifically Jude and Drew, as well as my own team and Carly Isles in particular, who've kind of made this all happen. So it looks effortless, but like a duck, they're gliding across the surface and paddling furiously beneath. So thank you all for the work you did to make this happen tonight. And I wouldn't be doing my job if I didn't finish with a rallying call. And the rallying call is this. I think this is a great example of how when we come together, when we share, when we connect, and when we learn from each other, we can be more than the sum of our parts. The work we do, both with IAPB and Vision 2020 Australia, is ultimately about collaboration, that if we all share, we can really make a huge difference. And now is the time, folks. Between the World Report on Vision, the Lancet Global Commission report, the kinds of developments we're seeing in eye care are remarkable, and together we can just make those sing for people who are at risk of or experiencing vision loss. So wherever you are in the world, whatever piece you're doing to make that happen, let's go forth and do it together. So on that note, thank you everyone for joining us. Take care and good evening, unless it's good afternoon where you are. Cheers.
Thank you very much, Judith, and I'd like to reiterate my thanks to you personally for coming up from Melbourne for this evening's event, and also thank you to your team who've been such wonderful supporters of tonight's event. This brings us to the conclusion of Focus on Glaucoma, not just here in Sydney, but right around the world. We could not have carried out such a broad range of activities without the support of the IAPB communications team in Hyderabad, the IAPB Secretariat in London, and our conference organising team, MYT, also in London. So thank you very much to those teams. Thank you, of course, everybody who's joined us virtually this week, not just this evening, but also throughout the week, through our other webinars. We really appreciate the time that you've taken, and we hope that you have learnt and enjoyed from the Focus on Glaucoma sessions this week. For those of you who posted questions this evening, we'll endeavour to answer those questions and get back to you. And now those of you that are here in the room with us at the Roundhouse, please join us for a drink and something to eat. The curtains will be drawn aside at the back of the room, and please make sure you have a green wristband as you join our post-event festivities. Thank you once again to the panellists and to Jude and all our speakers this evening. Good evening.